My name is Valentina Pasquantonio, and this is a presentation from the Legislative Health Specialists of the Massachusetts League of Women Voters. Today's program is all about health care coverage. There's a lot of discussion about it right now, and we thought it would be a good day, since it is International Universal Health Coverage Day, to discuss what health care we have available in Massachusetts and the nation right now, and then to have some experts in to talk to us about possibilities, because it is you and I who have to tell our politicians what we want in health care. I hope you enjoy the program. I hope it will give you some insight and some information that will be helpful to you. Hello again. My task is to tell you about all the medical insurance that is available in Massachusetts and the United States right now. That's a big task, so I've simplified it. I'm going to talk just about 5 different kinds of insurance, and in order for us to talk and remember things, I've assigned a visual to each of them. A playing ball, a tennis ball, a football, a basketball, and a color. That will become very important later on in the program when we start talking about the Affordable Care Act. So here goes. The simplest kind of insurance there is the military. We're using a baseball colored green to represent the military. If you are in the military pays for your health care, and you receive that health care from a military doctor on a military base or in a military hospital. This is called a closed system. The best example of an open system would be no health care at all. Because when you don't have health care, you can go to any doctor you want and any hospital you want to get medical care. However, when you don't have any health care, you have to pay for it. And health care is incredibly expensive. So you're taking a very big chance. And most people who unfortunately get ill and have no coverage end up financially destitute. In the United States, when we think about, did I say that was a black volleyball? If I didn't, we're using a black volleyball for no coverage at all. In the United States, when we think about health coverage, we usually think of private, for-profit insurance coverage. We're using a football colored orange for that. Now, although it is possible as an individual to purchase private insurance, most of the time we receive our health care insurance through our employer. And what happens is that there are about 5,000 insurance companies in the United States, a lot of them right here in Massachusetts, who will write health care coverage. And each of them will write hundreds of different health care plans. The employer checks this out and chooses anywhere from 1 to 5 or 6 different plans and offers those plans to their employees. Now, we've chosen the football simply because if you have an employer that has a larger budget, you might get 5 or 6 plans to choose from. But if you have an employer who has a smaller budget, then you might only get 1 plan to choose from. In these situations, usually the employer pays part of the premium and the employee pays another part of the premium. The employees are responsible for co-payments. The employees are responsible for deductibles. And these premiums from the for-profit private insurance companies are constantly going up. We just found out that in Massachusetts, the average insurance will be, private coverage insurance will be going up 7% in 2021. There are about, if we're in a good economy, no pandemic, almost 50% of the population is covered by healthcare insurance in this manner. In a bad economy, or when we're in the middle of a pandemic, when you need health coverage the most, it has dropped down close to 30% coverage. Next, Medicare, C-A-R-E. Medicare is for people over 65, and the general thought is, oh wow, after I'm 65, I've got it made, the government's going to pay everything. Unfortunately, that's not quite the case. For Medicare, we're using a soccer ball that's blue. Medicare has 4 parts, and Part A is covered by the federal government in total. However, the federal government requires that recipients, but there's also Part B, C, and D. And Part B, C, and D come through private insurance companies, with the recipient of the Medicare technically responsible for paying the private insurance fees. It is required that you get at least B or C. D is for drugs. B, being very simplistic, is an open system, and C is a closed system. You are also responsible for co-payments and deductibles. Now, at a certain level of income and above, the recipient has to pay these insurance premiums to the private insurers themselves. At a lower level of income, as the income goes down, then the federal government will subsidize the private insurance premiums for the recipients. That's Medicare. Medicaid, A-I-D. Medicaid is a federally mandated program run by the states, paid for mostly by the state, state and federal government chip in to pay for it, but the states run it. The state chooses who is eligible for Medicaid. The state chooses what kind of coverage they will give to these recipients. This is for people who cannot afford insurance in any way and do not work for employers who have insurance. Our state is very generous with Medicaid. We cover a very large percentage of our population who otherwise would not have any insurance coverage, any medical insurance coverage. But every state in the union, all 50 of them, have different levels of Medicaid coverage. That's important when we get to the Affordable Care Act. We're doing pretty good here. It's not the case in other states. Last but not least is CHIP, C-H-I-P, the Children's Health Insurance Program. Federally mandated, federal and states pay for it together, and this is for children of parents and guardians who do not qualify for Medicaid, but do not have the money to get medical insurance. This takes care of the children. And that's the 5 things that we usually think of when we think of healthcare coverage. But since we're in Massachusetts, I have to tell you about something else. Mass Health. Mass Health is Medicaid, just as I've described it, CHIP, just as I have described it, that are put into a bag and called Mass Health. One of the great and wondrous things about the journey through medical insurance or healthcare coverage is all of these cute little names that rename things. Next, I'd like to give you to Lindsey Stevens. Go ahead, Lindsey.
My name is Lindsey Stevens, and I work at St. Francis House Day Shelter in downtown Boston as a care coordinator in the Clinical and Recovery Department. St. Francis House is the largest day shelter in Massachusetts, serving roughly 500 guests a day. We offer a wide range of comprehensive services, including meals, showers, a stable mailing address, access to case management and clinical support, recovery coaching, workforce development, and access to an outpatient medical clinic run by Boston Healthcare for the Homeless. In Massachusetts, we are fortunate to have Mass Health, which is responsible for covering over 25% of all Massachusetts residents, many of whom experience financial hardship or disability. All of the patients I work with directly in my position, and a large majority of the patrons at St. Francis House and within the larger Massachusetts shelter system, are covered by Mass Health. Now a bit about my role at St. Francis House. I'm a care coordinator in the Behavioral Health Community Partners program. St. Francis House is one of 10 participating organizations within the consortium. Other partners include Pine Street Inn, Boston Public Health Commission, New England Center for Veterans, and Casa Esperanza, to name a few. This program is funded by Mass Health and is heavily focused on access to care, stabilization, and social determinants of health for individuals who are high utilizers of emergency services, meaning they frequently use emergency departments and other emergency supports in place of a more comprehensive and stable established care team. My team consists of myself, a Boston Healthcare for the Homeless nurse, and a Boston Healthcare for the Homeless team coordinator. Our team works with the client and their external providers to address social determinants of health, barriers, and complex medical care needs. In the 4 years that I have spent in public health, 2 of which have been in homeless services, I can say without a doubt that access to universal health care is absolutely essential to the survival of the vulnerable populations we serve. Healthcare does not exist in a vacuum. Health is the clothes you wear, the food you eat, where you sleep, who is there to support you, and of course, access to medical providers. The population I work with spends every day trying to answer those basic questions. Where will I eat? Where will I sleep? It's easy to see when an individual is living in constant crisis how less tangible, more protracted needs are pushed to the wayside. Individuals need to be provided the means to stabilize their situations, and I strongly believe access to healthcare is the place to start. Many people are aware that going to the doctor can help with immediate illness or getting a referral to other specialty medical providers, but there is so much more. Access to healthcare can provide the possibility of receiving financial support for individuals experiencing extreme financial hardship and living with a disability. This can come in a few different forms, but most commonly it is monthly benefit payments provided by the Social Security Administration via supplemental Social Security income or Social Security disability income. These benefits can take an unsustainably long time to be approved, but if an individual is connected to medical care, they can be approved for interim emergency cash assistance through the Department of Transitional Assistance while they wait. Healthcare access can provide access to medical transportation options known as PT1 in the Ride. Through the healthcare system, individuals living with disabilities can also qualify for reduced rate public transportation known as the TAP Pass. So now the individual has some sort of financial stability and a way to get to their medical appointments. Let's keep going. Individuals experiencing homelessness who medically qualify can be referred to supportive housing opportunities otherwise inaccessible without interacting with the healthcare system. The public housing system in Massachusetts is incredibly strained. Without medical and homeless priority, some individuals stand to wait up to a decade to qualify for subsidized housing, if at all. Another resource area that can be accessed through the healthcare system is food security. For those who are housed but are elderly or disabled and unable to navigate the community, through their healthcare provider, there are meal delivery services available. Last but by no means least, access to healthcare opens the door to long-term support services. This can include referrals to day programs, community support agencies, and government health agencies like the Department of Mental Health. Without access to healthcare, there is little to no possibility of receiving financial assistance from the government. Without access to healthcare, individuals who are financially strained or experiencing homelessness cannot get the medically necessary transportation they need. They cannot prioritize their housing. They struggle with food security. They do not have the tools they need to address their social determinants of health. Healthcare needs to be a right, not a privilege. Everyone has the right to life, liberty, and happiness. For the vulnerable populations we serve, access to healthcare vitally protects those rights.
Thank you, Lindsey. Now I have to talk about the Affordable Care Act. In 2010, the federal government decided that it was time for universal health care. This has always been a difficult thing for the United States. We have the idea that we want the concept, but we can't quite get there. And we'd like you to be the ones who get us there, the electorate. In any case, in 2010, the federal government decided that we should have universal health care. And what they did was take everything that has gone before, all the things that were going on, all those balls we were talking about, the red basketball representing Medicaid, the pink tennis ball representing CHIP, the orange football representing private for-profit insurance. All of those balls, they took them all and they threw them in a bag. And they said, that's where we're going to begin. Now, when you throw balls that are spherical, well, the football isn't, into a bag, they don't fit tightly together. So there were a lot of spaces in between. And also, one of the balls, as you'll remember, was the black volleyball representing no insurance at all. And we can't have that in universal health care. So the first task was to try to figure out how to get that volleyball smaller. And I'm going to tell you about 3 things that were done in order to do that. The first thing that was done was asking every state, or mandating every state, to up the ante on Medicaid, to cover more of their citizens under Medicaid. And the federal government would help with the payments. The second thing that they did when they were looking at that black volleyball and trying to figure out how to make it smaller was saying, oh, a lot of the people in that volleyball are people with pre-existing conditions because the private for-profit insurance companies refuse to pay or refuse to accept them for insurance. They would deny people with pre-existing conditions medical insurance because they were too expensive. Or they would charge the people with pre-existing conditions very high premiums that they couldn't afford. So the federal government said, no. Private insurance companies, you can't do that anymore. And the Affordable Care Act said, no, private insurance companies must accept people with pre-existing conditions. That shrunk that volleyball some more. But there were still a lot of people in it. Most of them were entrepreneurs or young people who were very vigorous and healthy and didn't see a real need for medical health care coverage. So the Affordable Care Act made it mandatory that everyone buy insurance, private insurance, or pay a tax. People had the choice, if they weren't covered by medical insurance, to pay a tax or buy the insurance. Now, if you will remember back, when we first started, I said that private insurance was very expensive and most people couldn't afford it. So the federal government took a page from Governor Romney here in Massachusetts, way back when, and put together an exchange. exchanges sound very complicated. They're really not. What makes them complicated is the way they've named them. Think of them as jewelry. Platinum is the best, then gold, then silver. Okay. These were the names of insurance coverage, the types of insurance coverage, going from the most precious of metals down to lower and lower metals. But in the Affordable Care Act, as it was envisioned, they didn't allow any insurance plans that could be considered base metals. They only wanted good plans to cover the citizens of the United States. And they went to the insurance companies, the for-profit insurance companies, and said, look, come into our exchange and offer platinum level and silver level and gold level and silver level plans to our citizens. Be good, because you're going to get a lot more people who are going to buy insurance from you, and that will be good for you. And what's even better, if our citizens have a problem paying because of their income, we are going to subsidize. So you're going to make out very well. And we've passed a law saying they have to buy it. Now, a lot of other things besides those three things happened in the Affordable Care Act. I like to think of it as taking all of these balls, along with the exchange, which to me visually looks like a cube, throwing them into a spherical Jell-O mold and pouring Jell-O into it to try to make it into a nice big ball that encompasses everyone. Initially, the Affordable Care Act was doing what it was supposed to do. The problems occurred when that Jell-O mold started to be picked away slowly but surely by different interest groups. And each of the time one thing or another was pulled away, it only affected a small portion of the population. So we weren't aware as an electorate of what was going on. The state said, no, we haven't been generous with our citizens before, and we don't want to be generous. The House and the Senate passed from one party to another. The administration passed from one party to another. Slowly but surely, little things were picked out of the Affordable Care Act, to the point now where that volleyball that we talked about that had been really reduced is now bigger. That's one thing that we need to take away from the Affordable Care Act, the ease in which it was pulled apart. The second thing, and to some, the most important part of what the Affordable Care Act taught us, is that 70%, over 70% of the population agree no insurance company should ever be allowed to deny insurance to a citizen of the United States or any person in the United States because of pre-existing conditions. Over 75% of us agree of that. 70% of us agree on that. And in the last election cycle, you saw what happened. When we agree, our politicians listen. Problem is, we don't know enough about health coverage as individuals to know what we want. So that's what this program is about. And now it's my turn to give you over to the experts. And we have some pretty special people. The first person to speak is going to be Dr. Randy Ellis. Dr. Ellis is a professor of economics, health economics, at Boston University. He has done a great deal of research on universal health care and is an expert on universal health care as it exists throughout our globe. But today, he has decided instead to talk to us about what he thinks would work in the United States in this political climate with the way the citizens seem to feel. In other words, economists like to see things that work. And he's sharing with us what he thinks will work for us. After Dr. Ellis, my mentor and another, or actually the legislative health specialist for the Massachusetts League of Women Voters, Janice Goodall, who is an RN and has been working on universal health care for many years, is going to tell you how the League of Women Voters decides which legislation we will back. She's also going to share with us what the League the Massachusetts League of Women Voters has come up with as an ideal universal health package. Ideal. After Janice will come two amazing nurses. Vedna Haywood, who is a trauma nurse and also happens to be on the board of the Massachusetts League of Women Voters and is a legislative specialist on racial justice. And her friend, Brenda Lormel, who is an oncology nurse, will talk about how what health care a patient has affects, often in a bad way, their treatment and the complexity of their treatment. It's very interesting. You'll want to listen to this. Lastly, we're going to be hearing from Dr. Arlene Ashe. Dr. Ashe is a mathematician, PhD in statistics and mathematics. She is a professor at the University of Massachusetts Medical School. And we asked Dr. Ashe to talk about how we afford universal health care. You're in for a treat. You got some pretty special people here. Enjoy.
Hello, I'd like to thank the League of Women's Voters for inviting me to give this talk today. My name is Professor Randy Ellis. I'm in the Boston University Department of Economics, and I'm here to talk to you today about how we can achieve universal, high-quality healthcare coverage in the U.S., something that's evaded us for 100 years. Why do we need it? I think you probably all know. We have 27 million people who are uninsured in the US. And surprisingly, many of them are young and healthy and wouldn't be that expensive to cover. But they may work for an employer who doesn't offer health insurance, or they're temporarily unemployed, or perhaps they're self-employed, but they choose not to pay for insurance given the current premiums. I think that one of the challenges in the US is that we tend to rely on employment-based insurance for working age adults. And this creates problems whenever people move around between jobs. There may be a gap in coverage, or they may be reluctant to retire or start a business or move off of their parents' coverage. And it's also true, a problem that happens is that we have a lot of uneven coverage. Some people have very high deductibles and a lot of cost sharing. or they may have very narrow panels of hospitals and doctors to choose from so that they can't find somebody that they want. So these kind of problems happen because of our hodgepodge of insurance plans and insurance coverage. And so I think a great strategy would be to build on the Affordable Care Act's offering of health plans in the marketplace. And these plans are currently available to everyone under age 65, and there are subsidies available for those who need it. What we need to do to finish the steps taken is to build on the subsidies, and we will need some requirements that if people aren't going to pay for their premiums, then they have to be willing to pay for a tax or a premium penalty. Because, you know, if they are going to not buy insurance, they're going to end up going to emergency rooms, and we're going to end up giving them coverage anyway. And so it's only fair that they have to contribute to the cost of those care. Now you can say, oh, but people want to choose. And I agree, I want to choose as well. I would like to encourage that everybody should have a choice of doctors, a choice of hospitals, a choice of which medicines they're allowed to use, and also a choice of health plan. This choice is embedded in our current system, and it will be painful to try to give that up. But I will point out that our hodgepodge of health plans often has very restricted sets of doctors and very restricted sets of hospitals that you can choose. And the medicines that are chosen are chosen by your health plan. So we actually have already accepted a lot of restrictions on our choice. And the one that I do favor is encouraging private health plans, but standardizing all of them so that they would be at a high level of coverage. The Affordable Care Act created metal levels, and these are, you know, bronze, silver, gold, platinum. I think that it would be terrific if we could agree that everybody should have at least gold coverage. And then if they want to get even more coverage, let them buy supplementary policies, just the way the Medicare program offers Medigap and other supplementary options. But by ensuring that we have this uniform standard for everyone of at least a gold coverage, then we could eliminate one of the nasty features of American health insurance programs, which is that insurers compete as hard to avoid covering really high-cost sick people as they do to offer high-quality healthcare. We want them to focus on low premiums and high quality, not on see if I can avoid the people who are sick. This is part of this central topic that everyone's talking about, of whether health plans can explicitly avoid people due to pre-existing conditions, or we also need to worry about them doing it not through explicit exclusions, but by offering health plans that are not attractive to people with significant medical needs. So the approach I would recommend is that we expand the choices of private health insurance plans, and we enforce that everybody has to be in at least one of them. And also, I think that we need to have a system in which we phase out the reliance on employers as being the sponsor of our health insurance. As long as we have employer-sponsored care where our health plan depends on where we work, we're going to create gaps when people move around or retire or set up their own business. Instead, we need to have health plans who are all offering insurance to anyone willing to sign up. So that would be the second leg of the proposal. Not only do we make consumers buy insurance, but we make insurers offer insurance to anybody who wants to join them. And so then if we did that, we could standardize the plans, and we could try to ensure that everybody's in at least a gold level of coverage that covers 80 to 90% of their healthcare costs. Now, you could argue, well, how are we going to afford this? Well, I would like to point out that the Affordable Care Act expanded coverage to 11 million people, and it was a budget-neutral government act. It actually saved money, according to this Congressional Budget Office. And it did lower the rate of growth of health healthcare spending for the first 4 years after it was in place. And if we could, have a willingness to consider revenue increasing strategies as well as coverage expansion strategies, then that would be something we could achieve with universal health coverage. Now, I do think you could ask, well, how are we going to control costs? And one of the first things we could do is we could have the government negotiate lower drug prices and make those prices available to all health plans. And we could regulate health plans to avoid some of the worst features of American healthcare, such as surprise billing and extremely high fees for certain kinds of healthcare providers and services. And I think we also need to build in more incentives for providers to provide high quality care, which a number of recent legislations has fulfilled. So I think that I have done some work on this, modeling what would it cost to cover everybody. And the answer is that it could cost less than $464 billion a year, depending on the nature of the features. And that may sound like a lot of money, but it's really not when you think, we also spent over $2 trillion on tax cuts, which were done without regard to how we're going to pay for our services. So there are ways of raising this kind of money and reducing spending by being more efficient. And I think that having an employer, moving away from employer to government-sponsored insurance that is private and covers a large, generous benefit package is an attractive option that most Americans could learn to love. And I really think that we need leadership that will help us move in that direction. And I think I will end right there. Thank you for listening to my ideas.
The Legislative Action Committee of the League of Women Voters is comprised of specialists who select, review, and recommend bills in their focus area and that are filed in the legislature. The bills must be consistent with positions of the state and national leagues. Both leagues declared goals under health as an affordable health care system that provides equal access to quality health care for all. The League of Women Voters of Massachusetts favors a national health insurance plan financed through general taxes in place of individual insurance premiums and does not oppose a single-payer system. Americans want a simple plan that is more cost-effective, more inclusive, and more comprehensive. Such a plan must eliminate much of the administrative waste and work for health rather than for profit. We want a healthcare system that leaves physicians free to provide care for their patients and provides what the doctor recommends, not what an insurance company decides or is willing to pay. The plan must negotiate with healthcare providers from each specialty for fair and equitable compensation that recognizes their experience, skills, and training. All residents will be guaranteed access without regard to financial or employment status, ethnicity, race, religion, gender identity, sexual orientation, previous health problems, or geographic location. Healthcare services will be continuous without the current need for repeated re-enrollments or changes when employers change new plans or residents change or lose their jobs. Patients will be able to see who they want, where they want. Entrepreneurs will be encouraged to work in their own businesses without the worry of seeking health coverage. We all deserve a more comprehensive plan that includes inpatient, outpatient, vision, dental, mental, and behavioral health care services, women's health services, nursing home, and some home care services, and that regulates the cost of drugs, devices, transports, and other services essential for life and health. And finally, it must include public health services that prepare for pandemics, improve vulnerable, rural, and underserved community access, and focus on infectious disease and prevention.
Hello, my name is Vedna Haywood. I am on the League of Women Voters for the state of Mass, and I'm also a nurse in a trauma ICU here in Boston. I've been a nurse for probably more than 20 years, working specifically in burn trauma and surgical ICU between two respective states. And just talking to you today regarding healthcare coverage and how I've seen it within my respective area.
And I'm Brenda Lormill, and I am an equity nurse practitioner here in Boston, Massachusetts. I've been a nurse for about 9 years now, and I am very honored to join the conversation with Vedna to talk about how we see healthcare coverage in our respective fields of study. I do oncology care, very different from burns, but different, but the same issues definitely exist. So I know, Vedna, you've seen your fair share of how insurance coverage, how, how when it's not universal, how it affects patient care, and it affects access. So I don't know if you want to take the lead and definitely tell us a little bit about what you see, and I could definitely give you my perspective from a cancer care view.
I can honestly say just in my area, because of some of our patient population is specific to trauma. So trauma is something that's varied. It could be anything from a car accident to shootings and stabbings. And so in that, it sometimes in terms of how a person is admitted into our hospital, it could be, yes, this emergent and a neighboring event that has happened, and so there's this ability to come into our hospital, or it could be that this is someplace else in another state or some towns away, and so then it becomes an issue of, what coverage does this person perhaps have, and what coverage is it that we accept. And so so with us being one of, I would say we have probably a few level ones within my within our city or the greater Boston area. It becomes difficult in terms of that patient and whatever their pathway is coming into my facility, because of the lack or the type of healthcare that they have, or may not have, for that matter.
Yeah, it's quite interesting. Sorry, go ahead.
Go ahead.
Yeah, it's interesting how you break that down in terms of your patient population, how it could be something tragic, right? Or you might have time to figure out what insurance that they have for cancer care. Right from the beginning, you're looking at who takes my insurance, what hospital, what provider, what center accepts my insurance. And unfortunately, I feel like that barrier is very high for a lot of folks living in the Boston area, because not all hospitals accept insurances that folks do carry.
Yes.
And so that makes you now have to make the decision, where do I get my care? And so if you can get your care at a hospital that's nearby and that provides great care, fair. But if your insurance is limited and you now have to either go further out, or the access to treatments at the hospital or center that you're trying to get your oncology care at is not the same,
Yes.
then it is just so, it's jaded. It's, you know, healthcare is a human right, we say, but then paying for it is not a human right.
Exactly.
It's far from that. You know, if I don't have the right insurance, I can't go, say we have 4 buildings, right? My insurance covers me here, but not here,
Mm-hmm.
but I progress, my disease has progressed, and they have this amazing clinical trial in building C, but I can't go because building C doesn't cover my insurance. So then what does that mean? I have to stay there, right?
Exactly.
It,
Or your
and when we
care
think about,
becomes
yeah,
tiered. Your care becomes tiered because say you started
yeah,
at hospital A because
mm-hmm,
hospital A accepted, said
mm-hmm,
insurance, but now your care has now tiered up to a different need. And so you are
mm-hmm.
now traveling in the midst of like this critical, time period to get to another center that perhaps you should have started with to begin with.
Perhaps should have started there, right?
Yes.
It's just, when we talk about healthcare coverage, Universal's great. Germany, I think there are a couple of countries that are doing this the right way, right? And I feel like universal healthcare is the right way because also what I see, for example, there's a lot of work that the MGH has done to try to accept other insurance coverages for cancer care that are predominantly utilized by the underserved communities, right?
Mm-hmm. Mm-hmm.
And a lot of these underserved communities, or let's even say the Black and Brown communities, are have the highest mortality rate
Yes.
for all, if not many, cancers. So they're doing that work. But that's great for cancer care. But their rates of death for other diseases are pretty high too, right?
Yes.
So they could come to this hospital and get the cancer care. But then what about everything else? So it's so fragmented, it's jaded, and we wonder why there's issues with non-compliance. I hate that word. To be honest, I don't think the patient's non-compliant. I think sometimes they're tired, right? For example, when you said you started at A, but you probably should have started at B, now you're traveling, you're building relationships with folks in A, but now you got to build relationships with someone else. It's not the same thing. You're not comfortable. They don't trust the system. We have to really think, like, what does non-compliant mean? And it's different in many settings. Maybe it's not non-compliant. The patient's not non-compliant. There are barriers,
Yeah.
right, that we need to figure out.
Yes.
To figure out why. And insurance is one of those major barriers that I think a lot of folks struggle with. Because again, healthcare is a human right, but depending on what insurance you have your right to voice how you feel or get the best care is limited. It's very much limited.
Yes, very much so. And I'll expand on that when I think, okay, so they've now, they're at my hospital. Say they've started at my hospital for their particular treatment, but they require some like long-term care afterwards, or some, specific treatment that perhaps is not needed in an acute care setting. Even then, even still, dependent on what it is you have in terms, or what you don't have, is where you're going to go for treatment, right, in order to phase out and then go back home. And so if you don't have that, this actually adversely affects your mortality.
Yeah.
It affects your mortality.
Or you can get in the door for a limited amount of time.
Yes.
Your insurance can cover you for a certain amount of days. And what if your stay gets extended for causes that obviously are uncontrolled? And then what? That's another extra added stress. It's like, okay, my insurance is going to pay for me to be here, right, in this long-term acute care setting, for example. And now I'm here longer than my 30-day cap for the year. Okay? And now I'm faced with, we have to figure out where to go with you, or this bill is going to be yours.
Yes. Which is an added stress.
Let alone the stress.
Yes.
Right. Let alone the stress of trying to, recuperate or pull through getting better or healing, and then having to deal with the stress of knowing I'm going to have this huge medical bill and I don't even know what I'm going to do with it because I can't afford it. Yeah. It's complicated.
It's complicated, and it's unfortunate that we don't have, this ability as to be equal in terms of our care that we receive for just baseline, whether it be preventative and or reactionary care. It's true. Healthcare should be a right. I think it leads to healthier societies.
Yes, ma'am. It does. It really, really does. And we talk about access right now. We're just only focusing on access. Think about prescription drug coverage.
Yes.
You have patients that, this is where, again, non-compliant. Oh, then, well,
yeah,
maybe they didn't pick up the meds because they didn't have the funds, because their insurance doesn't cover that.
Yes.
Or cover something else. It's, we spend so much time talking about access. There are other parts to it too, and it's like an onion, multiple layers. And, again, for example, the amount of time it takes to go through with all the meetings and everything that has to happen in the background for institutions to be able to accept, a new insurance plan takes a while. It takes years. People don't stop getting sick.
Exactly.
People are getting sick. People are dying. People are newly diagnosed. It's just, it keeps going. So you think if it was universal, we wouldn't really be spending this time trying to figure out who's going to take this insurance. Everybody's human right would be exercised at the highest, in the highest form, because everybody's access would be the same. Everybody's coverage would be the same, and we won't have to hop from hospital A to C.
Yes. And then
maybe we'd have more. Yeah, and wait.
Yeah.
And wait. And maybe we'd have more compliant patients.
Yes.
Maybe. It's unfortunate. It really is.
But the hope
is
that that we began to take some of these instances into consideration and move to something that is equitable.
Absolutely.
For all. Yeah. And so that we're on a level playing field as a society.
I agree. If we want to start somewhere, we could do all of the awareness and, and trying to build access. But if we're building access only to run into insurance barrier, I think the equity side can definitely start with insurance and policy, because that would really, really increase it. The equity, we think about equity, it's not just giving everyone the same thing, right? It's giving them what they need.
Yes.
Individually what they need. And if everyone gets the same insurance, they could pick and choose what they need, but not everyone is getting the same insurance. So
exactly.
To be continued.
Thank you.
To be continued.
Yes.
Nice conversation, Brenda.
Nice conversation, Brenda. Thank you for joining.
Hello, I'm Arlene Ash. I'm a professor at the University of Massachusetts Medical School in the Department of Population and Quantitative Health Sciences. As you can tell by the title of our department, we're interested, even though we're in a medical school, we're profoundly interested in population health. And I think the most important thing for people to understand when we think about paying for health in this country is that health is worth something. It is one of the most valuable things that we have. And it's worth it to pay to have better lives. And it's worth it to become a more healthy population, a more healthy country. So when we consider whether there's something that we're willing to pay for or not willing to pay for, we have to really think about value. We have to think about becoming a healthy nation at a reasonable price, paying for the things that are valuable to create health. As you probably know, that health is different than simply an absence of acute disease. If you're not sick, but having a lot of problems in your life, you don't have an acute problem, you're not necessarily healthy. So it's very important to be able to have those resources for when you're hit by a truck and you need to go to the emergency room and you need specialist care, and you have things where we have wonderful resources for dealing with those acute problems. But half of the adults in this country have a long-term chronic disease. Maybe a quarter of them have at least 2 long-term chronic diseases. And what we really want to do is we want to create a nation in which we reduce the incidence of that chronic disease. And when people have chronic disease, we learn to work with them to help make sure that it has minimum impact on their lives, that the bad consequences of long-term chronic diseases are pushed off and maybe averted entirely. What we have learned is that market incentives don't work in this environment where so much of what we're looking for in health care and in health is long-term maintenance of a healthy life. Why? Because you have a lot of independent competing organizations which are taking care of you for now, and they're looking for their return on investment on anything they spend today within a year or two. But take a person with diabetes. This is a long-term disease which, if well managed, does not have to interfere that much with your life. And if poorly managed, you will end up going blind or having to have some limbs amputated. So an organization which doesn't expect to be taking care of you for more than a year or two is not going to have any incentive. There's no way we can use monetary incentives to get them to do what's needed to keep you healthy over a lifetime so that 10 years from now you don't have to have your leg cut off. So there's many things that are wrong with our non-system of healthcare delivery today, and they're not going to be fixed unless we're able to get the money allocated in a way that is designed to improve long-term health outcomes. So when I talk about diabetes, it's a very good microcosm, not the only example of a disease in which it would be really important to pay attention to the long term, but it's a very good example. For example, some of the people with diabetes have so-called type 1 diabetes. They're born without the ability to manufacture their own insulin. And for them, it's a very simple question. They get their insulin, they're able to live. They don't get their insulin, they're not able to live. There is no reason that in this country we should be charging people amounts of money that they can't pay in order to get their insulin. So neither should the country as a whole be paying some sort of premium to someone who controls the production and distribution of insulin because they have a monopolistic situation. But the government should see to it that this material is never in short supply, that it's produced at cost, and that anybody who needs it gets it for free. There's no reason to charge a copay. You don't want people to say, oh, maybe I won't get my insulin today because I don't have I have enough money to do it. There's another type of diabetes which is even more common, and it develops in later life, and it's a combination of a genetic predisposition and lifestyle factors. To protect people from developing type 2 diabetes, and to protect them when they have it, to minimizing the long-term consequences, there are many things that can and should be done that we know what works and aren't being done because of the dysfunctional way in which we finance healthcare. So you need a lot of attention at the bottom of the healthcare pyramid. You want to have community health workers working with people to teach them about cooking better foods, about healthy style lifestyles. You want to actually have a partnership with public health so that people have safe places to exercise, so that they have food outlets that are selling healthy foods near them, so that when kids are in school, they're getting healthy foods and they're learning about lifestyle habits that will keep them from developing diabetes. So there's an enormous number of ways of thinking about an individual ailment as something that could be treated, not just in the end stage with the surgeon cuts off the person's leg, but as a long-term investment in the health of the public. There are other kinds of diseases like asthma, where we could control sources of pollution, and that would reduce how much asthma there is and how often we hospitalize people for asthma, as well as working for people who have the disease to teach them how to manage it and not end up in the hospital. So I think the most important thing in this extremely short talk is to understand that population health is a public good. It's worth paying for. Other countries have a lot of different ways of figuring out how to pay for it, which work better than what we have. And we can do it. That at a minimum, in a very conservative way, administrative waste from all these trying to figure out who's responsible for paying for you when you get sick, that's at least 10%. That's a huge amount of money. That's running in the neighborhood of $400 billion. I mean, it's a lot of money. So, not enough time to tell you how we're going to get there. In the short run, there's lots of transition problems to solve, but workforce realignment, focus on comprehensive everyday interventions to help people be healthy, integrate the healthcare delivery system, public health, and the community. These things will, in the long run, we know that in the long run, they will more than pay for themselves. How can we afford to pay for this? Better we should ask, how can we afford not to?
Welcome back. I hope you enjoyed all of our wonderful people who have given so much of their expertise and time to us. We appreciate it. For fun, I thought you might enjoy seeing a real ball. Actually, this is the ball that Janice and I would like to see represent universal health care in the United States and in Massachusetts in particular. For those of you who don't recognize it, it is a physical therapy ball. It is meant to be sat on. It is very sturdy. You sit on it and your core is made strong. We hope you will remember some of the things that you learned here today. We especially hope you will remember what happened when 70% of the electorate decided that pre-existing conditions had to be covered, no matter what. Universal health care, the politicians have been trying to do this since Harry Truman's time. It's time for you and I to get ourselves together, to have the discussions, and to lead them and tell them what needs to happen. Thank you for joining us. We hope your International Universal Health Coverage Day, 12/12/2020, was a good one. Bye now.